Good morning and hello everyone. Welcome to today's event, Past, Present, and Future, HCCNs and Health Centers Using Data to Drive Clinical Care series. This is part 2 in our series, which is the HCCN's Current State, sponsored by the National Association of Community Health Centers. My name is Elizabeth Breidenbach. I'm a meeting and event specialist based in the Clinical Affairs Division here at NAC, and I'm pleased to bring you this event along with my division colleague, Ron Yee, the Chief Medical Officer and Senior Vice President of the Clinical Affairs Division. Before we get started, I would like to review a few housekeeping announcements. You have joined this online event by either physically calling in or using computer audio. All attendee lines have been muted and will be muted for the duration of this live event. This live event is approximately 45 minutes, including introductions, presentations, and Q&A. Again, the duration of this live event is approximately 45 minutes, including introductions, presentation, and of course, a live Q&A. So some of you have submitted questions in advance, and we truly do appreciate that. But again, of course, as the presentations go through, questions will come about, and you'd like to pose that to us. So using the Q&A box that's located in the lower right-hand side of your computer screen, simply type your questions in at this box at any time for the duration of this event. Make sure you select to all panelists and hit send. Again, the Q&A box is available for the duration of this event, located in the lower right-hand side of your computer screen. Simply type your question in. Make sure you select all panelists and hit the send button. If for some reason we cannot answer your question in the time allotted or we need additional resources to answer those questions, we'll make an attempt after the event is completed. Friendly reminders, today's event is being recorded and all attendee lines have been muted and will be muted for the duration of this event. The Q&A box is open currently right now and available for you to pose those questions. And again, if we cannot answer your questions in the time allotted, we will make an attempt after the event is completed. At this moment, I'm going to turn things over to Ron, who will be introducing today's speakers and setting the stage. Ron, the floor is yours.
Thanks, Liz, and thank you everyone for joining us today. I wanted to set things up for our session today, and I wanted to provide some context and some details and a connection to our webinar last week. So last week, we did Looking Back, the birth of the HCCNs. And we had Dick Bohr, the past director of the Community Health Center program, and Fred Rockman, the co-founder and CEO of the Alliance Chicago Network for the past 2 decades. Working with HRSA and the Bureau of Primary Healthcare, the focus of the HCCNs was to produce actionable information to bring about positive change for health center operations, clinical outcomes, and financial viability. And they started with a group of health center leaders that gave up a little independence for the good of the larger network. Like the members of health centers, the board being made up of users and patients, the HCCN board needed to be made up of users also. So in webinar number 1, we emphasized how HCCNs can leverage the resources to support a large number of health centers, taking advantage of group purchasing, shared training, and other economies of scale. And we were able to celebrate how far the HCCNs have come over the years, advancing the HCCN objective to position the health center movement to be able to respond to current drivers in the environment in new and innovative ways. They are known for their innovation. So this webinar today will take a closer look at how HCCN activities presently support the health centers, the current state. And we're honored to have as our speakers today, Tracy Orloff and Jason Greer. Tracy Orloff is the Director of the Strategic Partnerships Division in the Office of Quality Improvement in HRSA, the Bureau of Primary Healthcare. Her division ensures that the Bureau of Primary Healthcare grantees and staff have access to mission-critical training and technical assistance. And Tracy manages and coordinates all PCA, HCCN, and NTAP grant program activities. Our second speaker, Jason Greer, is the CEO of the Colorado Community Managed Care Network. Jason's been working with the Colorado HCCN, PCA, and the FQHC family for over 20 years, and the co-chair of the HCCN task force for the past 2 years. His work's focused on learning how to use data as a strategic asset for health centers and how to use technology systems to create meaningful and measurable change in the healthcare system. So we're just so privileged to have them to be our speakers today, and I'll turn it over to Tracy. Tracy?
Great. Good morning, everybody, and thanks so much to NAC for the opportunity to join all of you today. I really appreciate it. And so I'd like to share BIPIC's perspective, the Bureau of Primary Healthcare's perspective on both the current state of the HCCN program and the real value of the health center controlled networks and the important support they offer to health centers including through the COVID response and future recovery efforts that are coming at us. In the last decade, HCCNs have led the charge in moving the needle forward to increase adoption of health IT across the health center program and empowering providers and patients alike to harness the power of technology, information, and data to improve the value and quality of the healthcare provided. HCCNs have provided critical support to health centers with EHR implementation, helping them to navigate various challenges around software selection and vendor contracts, to implementation support and workflows, as well as workforce training. Following widespread adoption of EHRs at health centers, BIPIC then asked the HCCNs to shift focus to optimizing the use of technology and facilitating the use of EHR data to support patient-centered medical home transformation and, of course, quality improvement at both the care team level and the population health level. We then raised the bar again and shifted our focus to improving the exchange and usability of interoperable data across EHRs, and while tapping into health information exchanges at the state and regional level to access data from different local, state, regional, and national sources to inform care delivery and improve social determinants of health. And so you can see we had this whole evolution, and with the current round of funding, we then shifted again. So this is pretty much every 3 years, evolving as changes are rapidly happening. And so we changed the focus again in response to those national priorities that we see now in the last couple of years, and then the unique needs of health centers. So this resulted in the need for the HCCNs to be able to address the increasing level of sophistication of HIT, and so addressing the complex data access and exchange challenges around interoperability across EHRs, meeting health centers' cybersecurity and data protection needs, and then addressing the increasing level of provider burden that has emerged as a result of all this work and using these technologies, all the while balancing the overall goal of providing value-based healthcare. And so during the last decade, we've seen a lot of results. So we've gone from less than 25% of health centers with EHRs to 99.8% of all health centers using ONC certified EHRs installed at all sites and used by all providers. We've moved from less than 1% patient-centered medical home recognition to 75% of all health centers with this care delivery model and recognition. And then we've shown tremendous improvement in clinical quality outcomes as noted by our Quality Improvement Awards, which most of you have been part of, and then external evaluations and studies. Evidence has demonstrated that health centers that collaborate with a health center control network consistently perform better on quality, key clinical quality indicators. And so we continue to try and make sure that as many health centers participate in the HCCNs as possible. And so to the current state of the HCCN program, just to give you a few statistics, you guys know a lot about it, but just to do a recap, in 2019, BIPIC awarded $42 million to 49 health center control networks to enhance their health centers' use of information technology. And then in addition to respond to the COVID public health emergency, we also, and to help maintain and increase the health center capacity to respond using their health center EHRs and the breakdown of data with their vendors, we also have been awarded $4.5 million to all those same 49 health center control networks. The focus of these grants was to provide specialized training and TA to leverage economies of scale. And so that includes health IT platforms and interoperability standards, best practices and training, and then data analytics to support quality measurement and clinical decision support on the ground, day to day, and improvement of the outcomes that we're seeing. So currently there are 1,190 health centers, which represent 83% of all health centers and 46% of lookalikes who are members of the health center control network. And these are state, regional, and sometimes cross-national health center control networks. We have a mix of all three of those types. We find that health centers that are members of a health center control network are better skilled in data collection and analysis, have strong quality and performance improvement processes, and are really efficient in the ability to provide accurate and timely data reporting. For these reasons, work continues to encourage other health centers to participate in and join them, and join HCCNs, or if they don't, to work with them, because a lot of them can work together without being part of each other's networks. And so they do that as well across the country. So in terms of the telehealth capability, which is also a very vital key to unlocking health center access for many of the patients receiving services at health centers, there's a need to increase the capacity of health centers to deliver services via telehealth and virtual care. And so on the 2019 UDS, we saw, and this is before COVID, 43% of health centers reported providing services using telehealth technology. During COVID, that went up to 90%. So, and we're hoping to keep those doors open and take advantage of that as much as possible in real time and keep that momentum going. And so, but the statistics in 2019 also showed that 75% of health centers were already using telehealth for mental health services, 28% for primary care services, and then 32% for substance use disorder treatment services. So we have a good momentum, but now because things have opened up with COVID, we're going to be able to move in that direction much, much faster and then provide continued support to health centers to keep pushing in that area as it fits well for health centers and their patients. So in terms of the objectives of the health center control networks, they're really to use and leverage HIT to increase participation across value-based care for three major categories. Enhancing patient and provider experiences. And so with that, we're looking at increasing patient access, patient engagement, and then reducing provider burden. The second big area of advancing interoperability is a major objective as well. And that's where we're focusing on increasing data protection, increasing health information exchange access, and increasing data integration. And then the last main category is using data to enhance value, improving and increasing data analytics, social risk factor intervention. And through an emerging applicant, we have an emerging applicant goal where health centers in the networks can identify things that are unique to what they need on the ground with their own health centers in their environment. So in support of the COVID-19 response, 49 HCCNs applied for and were funded for that additional supplemental funding, and that money and that work complements the base grant itself. And a lot of those activities are focusing on patient portals, telehealth, EHR enhancements, again, this health information exchange and other activities that align with the current goals but help address what's going on with the pandemic and what the needs are, helping that negotiate with vendors, things like that. So in terms of the results, just want to share a couple of results, both looking back to the last cohort, which was 2016 to 2019. Just a couple things to highlight there. 93% of the HCCNs generated quality improvement reports at their site and clinical teams level. So they were using it to feed that direct provider support on a daily basis. 88% integrated data from their different service types and providers, and then 89% also used their EHRs to electronically extract their UDS reporting data. And as I mentioned before, health information exchange is really critical, and 79% had improved care coordination through their HIE with unaffiliated providers and entities. So that's really important so that, again, wherever our patients go, there's a way to find out what's happening to them and get those connected. So in terms of the first year of this current grant, we've only had 1 year's worth of data, and so they had some different measures. And so, for example, enhancing patient engagement, one of the areas we looked at is participating health centers who were improving their health IT usability. And so that went up in just that first year from 31% to 42%. So people are making inroads very quickly on kind of these enhanced next steps of what they need to do with the sophistication with their HIT and how they're using it. In the area of advancing interoperability, we have a number of things here. We have primary participating health centers leveraged health information exchange to improve data exchange across hospitals, health centers, and their state in departments of health, local departments of health, regardless of the EHR used. So that's really great. And there was about 52% that have made progress from 42% just at the beginning of that same year. So again, moving very rapidly. And then the HCCNs have also consolidated clinical data with data from multiple sources across the health center continuum. And so that's tapping into lab data, state registries, those kinds of things. And we're almost at 50% for that, starting at 33% for that first year. So, and then the last stat I would share, and then I'll stop with that, is in the goal of using data to enhance value. A number of the participating health centers across the HCCNs have been improving their capacity for data standardization, management, and analysis to support value-based care. And they started the year at 68%, and they're already at 88%. So it's pretty incredible, the range of things people have been doing very quickly, very fast. And we will be getting data in the next several months for the second year. So we're really excited to see the momentum continue. So the last thing I wanted to end with is really talking about kind of the future of where the HCCN program is going in the next couple of years and our expectations. And as we look to the future with the continued response and recovery efforts that will be involved for the COVID pandemic, we believe HCCN support will continue to be paramount to the health center success. And so the pandemic has once again confirmed that the only thing we can be certain of is change. And both the healthcare delivery system changes, health policy, state and local environments will continue to evolve and must evolve to meet the needs of health center patients across the country. And so when health centers work together to leverage economies of scale as they do in health center control networks, they share data, they maximize their ability to benchmark and rapidly learn from each other and improve, and they're better positioned for success. And together, the health centers in the HCCNs are able to achieve more, and, you know, particularly in areas like rural areas, where they really would be disconnected, and that takes that away and helps raise the bar of what they can do by working with others. And a number of you may be aware that we've been thinking about the future of the health center program in BIPIC, and we've been talking a lot about BIPIC Reach and some of our changes that are coming. And as we look ahead towards our vision for the health centers to be leaders in primary care and population health improvement, and as well as models of operational excellence and value, a key factor in achieving this vision is strengthening our health center control network, leveraging the collective power, whether it's buying power, insights from the volume of data you have or can use to influence others, given the numbers of patients and communities you serve, and then working together, we'll be able to maximize the impact of your individual resources. Individual health centers or smaller rural communities often lack the volume of data, analytic capabilities, or the workforce needed to fully leverage technological advancements and advanced analytics. Or they sometimes engage in research alone. But together, in state and regional networks, health centers have the ability to bring sufficient value to the patients, providers, and the communities you serve. You'll also be able to tap into the national collective of a network of networks. And so as we continue to create a robust learning healthcare system for health centers, particularly through post-COVID period, that information rapidly moving, learning from it, leveraging from others is going to be just critical and so important to make us all move faster and be able to address everything that we're trying to do at the best possible levels. So you will continue to see a growing emphasis on health center control network collaboration and partnership, peer learning to speed up the spread of good ideas and information and how we do things, and then the use of data and innovation to drive impact and value from both HRSA and BIPIC, which helps us tell the health center story. And telling that story is very, very important. So I will stop there. I just want to thank you all for everything you're doing for your patients and communities every day right now and always. And we really look forward to our continued partnership in advancing the shared mission. And so I look forward to your questions after we get to that point. Thanks.
Good. Thanks so much, Tracy. Really great summary of where the HCCNs are today, meeting Bureau and network objectives, and then the impact going forward. So thank you so much for laying that out. So now we'll move to Jason Guerre to share some comments. So Jason.
Great. Thanks, Ron. Thanks, Tracy. Really appreciate the Bureau's ongoing support for the HCCNs, and what a great summary. So thanks for covering all of that. And then Ron and the NAC team, thanks so much for the opportunity to help build awareness of HCCNs on a national scale. There's lots of good work happening across all the HCCNs, and I feel lucky to have the chance to get to talk with you guys today. So hello from snowy Colorado. A little bit about the Colorado HCCN. We are an independent organization. We are separate from the Primary Care Association and from the ACO. But we all operate as a family together in Colorado. There are 20 health centers that we all support. They've got more than 200 locations. They're striving to hit around 1 million patients per year, and then we see about a third of the Medicaid population. The purpose of our HCCN is to really try to figure out how to use data and technology to focus on business priorities of the family, public health priorities, and then, of course, policy priorities. A brief summary about me. So I was the IT director within one of the health centers for about 8 years, and then I moved to the HCCN, to the network, as the CIO, and was a CIO here for about 4 years, and then became the CEO of the network about 8 years ago. And I've had the privilege of co-chairing the NAC HCCN task force for the last 2 years. When I was the IT director at one of the health centers, the HCCN CEO and staff would come to visit, and we would always welcome their visit, but I remember feeling really nervous about their visit and really wanting to make sure they were aware that we did a lot of really good work within the health center, wanted to just kind of really show and kind of shine a light on all the important things that we were doing. And they would show up and they'd want us to get involved in their programs, and I was a little bit concerned about my own kind of career growth within the health center, if the HCCN was going to come in and start doing things that I wanted to do around kind of data and analytics as the IT director. And where we landed, it was a conversation around trying to figure out that balance between the HCCN's role and the health center's role. And I remember having kind of an awkward conversation with the HCCN CEO at the time, and where we landed was I said, hey, let's figure out how the HCCN empowers us. Let's figure out how the HCCN helps protect us, and let's figure out how the HCCN and the health centers can be stronger together. Like, how can we all make ourselves stronger together? And so, interestingly, ironically, fast forward, 15 years, and now as the CEO of the HCCN, I see it as my responsibility to hold true to the promise that I made to myself 15 years ago, where it's my responsibility to make sure that I'm empowering health centers, that I'm protecting health centers, that I'm helping make all the family stronger together, and I'm actually helping create a growth and a career track for the staff in my organization, but also the staff within the health centers. Okay, next slide, please. Let me jump into kind of what the current state of our HCCN is today. If you look at this is kind of the macro view of how I see our organization and kind of what our role is inside the network. And so our core of the work is around the data, right? So we do collect a lot of data, and I'll get into what that data is here in a second. And then the next thing that we do is we have a structure called a data vault. And so that's a way for us to manage the data with the health center staff and their community partners. Then the next layer, of course, is getting into analytics. And so what can you do with that? What kind of information can we deliver? We, of course, like everybody, believe that and know that information is a very powerful tool. Information used correctly can make positive change. Information used incorrectly can make negative change. And so we're trying to really figure out how do we use information and then place it in a way to make the most positive and meaningful and lasting impact that we can. We want to try to harness the expertise across the entire network of all the staff at the health centers and the PCA and the ACO and the network. And so to do that, let's jump into the systems, and I'll kind of walk you through how we do that. And so next slide, please. And so this is going to start at the bottom layer with the data. And so the data that we have today, we store data on approximately 2.5 million people. It primarily comes from the health center's EHRs. We have EHR connectors that pull in data on a nightly basis that allows for that. And then from there, we collect other data points and combine it all together. So we collect claims data. We have an all-payer claims database in Colorado, which we're fortunate to have. So we have Medicaid, Medicare, and about 7 private plans worth of data. We have state-based HIEs, so we collect the admit and discharge data from the hospitals. We collect social data from the health center's EHRs through the Prepare tool, and then from some of their community partners. We get daily Medicaid enrollment data. We get national LabCorp lab data, and then we get public health data from the state public health department around birth and death records. And so the data set is actually pretty significant. And of course, you have to run data management and kind of cleansing tools on top of that, like MPIs to match who's who across the different data sets. But that's the data kind of stack as the way that we start it. In the data, of course, collecting data and holding it doesn't actually do anything, obviously, but it actually has a pretty significant cost to it. And so we've got kind of more than $1 million in just operations cost in collecting and kind of managing the data foundation. Then it's a matter of kind of doing something with it. And so let's go to the next slide, please. And so the next slide is starting to describe what we call is a data vault. It's a relatively it's a growing product for us. We've been evolving this over the last several years. But at this point, what it can do is it allows us to make the data available to the health center staff that we collect on their behalf. We want to make sure that they have full access to all the data that we collect. And so what we do is we have these cloud-based databases that we provide, kind of one for each health center. So that way they can load data into it. They can see the data that we have access to. They can provide sharing mechanisms from that database into others so they can see it. Really the goal is to try to bring tools into the health centers because the health centers have just an enormous amount of expertise when it comes to engineering and business intelligence development that we really want to try to find a way to leverage. And so inside these data vaults, this schematic here shows that there's the green ones, which are essentially one data vault per organization. So the Clinica is one of our members. Mental Health Partners is one of their behavioral health community partners. And today we have data vaults at both, and they actually can share data between them. They can both let us see the data in their systems, let us do analytics on top. And then the red one on the left side is the reference data vault. So that's where we can give Clinica access to all the data that we are collecting on their behalf, and then they can run their own BI on top of that and use the data vaults as their own primary data warehouses for their organizations. And then we can set up a reader system so that we can read data as they allow us to do that. And so the goal is that we've tried to create a model where we can create kind of self-service access to data, but also it allows us to leverage the strength of the health centers and the HCCN so we can provide engineering services to help out with that whenever they would like for us to. Other use cases with the data vaults is that we can be plugged into national and local research networks. And so we have the CODI project, we've got Million Hearts, and we've got this CORDS, which is a distributed data model using PopMedNet and all that nerdy stuff to try to help create national research initiatives with the health centers. That the HCCN can do all that for them. Okay, let's see. Let's go to the next slide, please. I want to show you kind of the current state of what the data vaults look like across Colorado. And what this is essentially, we like to call it the honeycomb because essentially it's a data vault for each green data vault is each one of the organizations. Each one of the red data vaults are the reference data that we can make available to organizations. And then the blue ones are the current and upcoming reader vaults so that their community partners can get access to it. And then the idea here is that organizations can actually just see, they can see the data they're allowed to see, but organizations can stay in control of the data that they want to share across their community. So really feel like this supports the HRSA scope and data availability and interoperability. And okay, so, and Ron, my slide didn't change yet. Are you still on the, do you see the honeycomb on yours?
Yes, let me see if I can have Liz change that. We have a little bit of a lag here, I think. So Liz, could you change that slide, please?
I see the honeycomb on my end. I'm not sure. Okay. Yeah.
Okay, thanks, Liz.
Maybe one of my other next. Yeah. Okay.
But let's go ahead and go to the next slide, which is the overlap report, and just let me know when it's there, because I have not seen it on mine just yet.
It's there.
Okay, great.
It's there.
Okay, and so this, once it comes up for you, it's an overlap report. So I want to jump into the analytics side of the things that we do. And so really quick, this is essentially for every organization using one of these data vaults, we can then look at their populations and we can see the overlap of their population between each one of their organizations. So we can see how many clients they share. We can start to have discussions about who's on the patient's care team between organizations. We can see what data and what PHI can be shared between organizations because they both have treatment relationships with them. And then we can start to tell the story about the outcomes through analytics of the shared populations. All right, let's go to the next slide, please. And Ron, mine still hasn't changed yet, so I'm assuming folks can see it okay.
It's not changing on my screen either, Jason, so I apologize. I think for some reason it's delaying or not responding to us trying to advance the slides. So I don't know if there's another way we can advance them, Liz.
Yeah, I'm going to go ahead and upload a brand new deck, so just give me a second. And Jason, feel free to continue while I switch things over.
I'll just keep talking? Yeah, no problem at all. So the next slide, if you can visualize it, is the prepare analysis. And so we collect social data from all the health centers that have the prepare tool running and allows us to really look at the social profile of their population and allows us to combine that with their clinical profile so we can really tell the story of kind of what's going on from a population perspective, from a clinical and social perspective. It allows us to really kind of create new discussions about the risk of the population. And so when the ACO gets into payer conversations, we have just real evidence that the population really does have social barriers to care that need to be addressed. All right, the next one is going to be a COVID surveillance system, and so thanks to the Bureau for their financial support and helping us build this together. What we did was we built a COVID surveillance system on about 1 million people that monitored for hospital visits, and so when people showed up in the emergency room with COVID symptoms, we would get an alert within a few minutes, and we would alert the primary care provider and the care coordinators to do an outreach same day so that we could then start to track them in a cohort to see did they have, did actually an infection occur, did they need education about what to do next if they thought they were infected, did they get a chance to have a social assessment to understand if they had any social barriers if a COVID infection was about to start. And then from there, we were able to start to tell the story of the population so we could start to look at what's the profile of the population, tell the health equity story if we could, and then now we're trying to get into monitoring long-term effects of the population that got infected. And then from a vaccine response perspective, we're working on the efficiency of the outreach process. And so we're trying to figure out, can we, if the FQs are responsible for about 1 million for about 1 million people, which is about 2 million vaccines, we need to know who needs it and who's eligible, who got the first one and which vaccine did they get, who needs the second one and which vaccine did they have to have, who got both and is finished. When it comes to the coordination of about 1 million people for the vaccine effort, I think that there's going to be a lot of need for pretty tight controls on who needs it and who doesn't need it across the population. All right, let's jump into the next slide. If that's going to come up here pretty soon, it's called Medicaid enrollment, and we use the Medicaid data on a daily basis to talk about tell the health centers about the churn of the population, and so they can know who rolled off of Medicaid so they can outreach and try to get them back enrolled again, who's been attributed but they haven't been seen before because those patients are going to be in their population for the key performance indicators, so we got to get them in and get them seen. And then we can look at kind of statewide attribution trends. Great, I see it now, thank you. So we can look at statewide trends and kind of what's going on from a Medicaid attribution perspective. Okay, let's go to the next slide, please. And then we get into performance measurement. So big conversation across the health centers, right? So of course we measure their UDS scores, we measure their Medicare shared savings, you name Medicaid scores. But one thing that we try to focus on is really telling the story in a way that that claims data doesn't do. And so we combine clinical data in with the claims data. And the slide, if you can see it, shows that by adding, from a depression screen measure, adding clinical data jumps the score up dramatically. And so it gives us a chance to have a discussion with the health centers about whether or not they want to try to improve their coding, or do we want to try to talk the payer into receiving EHR data so we can avoid the health centers from having to actually make coding changes in their practice just to hit the KPI, because they're doing the work anyway. And so from a provider burden and staff burden perspective, this is a good way for the HCCN to try to support the health centers without making them do a bunch of coding changes just to try to hit the KPIs that they're actually already hitting. Okay, next slide to claims analysis. And Ron, mine's not updating again, and so I don't know if it's updating for you either.
Yeah, I apologize to the group. We will post these afterwards. You know, sometimes we have these glitches no matter how much we prepare. So sorry for that. Go ahead and continue, Jason. Yeah, just explain to them what you're talking about here.
Yeah, you bet. And it's just my mojo. It's just what happens whenever I'm presenting from home. All right. So we do claims analysis. So really quick, we tell the story of the cost of the population. Then we try to demonstrate that waste isn't in the primary care side of the equation. And we want to tell the story that more money into primary care actually can create better outcomes and reduce total cost of care. That's, of course, a work in progress. The claims are hit or miss if they're usable or not, just depending on the year. But that's an important piece that we're working on. Next slide, please. We also provide the Azara application for providers, which is great because we're on all different EHRs across the state, but having one application that allows them to have a single tool for PCMH and Medicaid reporting and UDS, specialty reports, tracking cohorts. It's just a really, really cool tool to provide across the entire state. So we have all of our health centers using this application at this point. Okay, and then next slide, please. And then I think this is my last slide. So the last thing that we do is community coordination. And so we take all that data and systems with the FQs and really focus on integrating them across their community as much as we can. So we have a community care coordination application that has kind of role-based access for everything from FQs to behavioral health to community-based organizations to log in and try to act as the same care team together. We were having discussions this week about how to get the library plugged into it. And so the idea is that we can try to help the organizations do a better job with community care coordination, managing social determinants, and then having a more efficient experience for the person as well as for the care team. And so with that, I think I'll stop there, Ron, and turn it back over to you, and I'm happy to answer questions if there are any.
Yeah, thanks, Jason. You know, appreciate you sharing your own journey, but also, wow, it's amazing the data that you guys have, like for the vaccines and then for the payers. That's exactly what the health centers need. So thank you for really fleshing that out and giving us the data. And as Tracy said, we're trying to tell the health center story, whether that be payers or funders, you know, or the public. And so thank you for the great work. So we're going to take a few minutes here. Thank you, Tracy and Jason, for some Q&A. I'm going to turn it over to Cassie and see if she has either some from the question and answer box or other questions that have come from the field. So Cassie?
Hi, everyone. We do have some questions. So our first one that came in are, what health centers are working with payers to add claims and pharmacy data to their EHRs? This person is trying to have these conversations in Indiana and is getting mixed responses from payers. Is there a contact that has successfully implemented data feeds?
Hey, this is Jason. I can give it a quick shot. And so,
Go ahead, Jason.
Go ahead, Jason.
Okay, yeah, so, you know, I don't know. We have not been able to move claims data into EHRs at this point, only because I don't know that I'm not aware of the EHR vendors that are ready for that. But we do have the chance to move it into some of our applications, like into the Azara application. They can receive that at the point of care for using claims. But I think it's a great opportunity for NAC as an association to really help us facilitate the discussion nationally about how we can make sure claims are available on a national scale.
Cassie, other questions?
Great. Yeah, excuse me. Anything to add to that, Tracy, or we do have another question here?
Unfortunately, I'm getting a word. I'm sorry. I can't hear you.
He's breaking up. Yeah. Go ahead, Cassie. Go ahead and move on, I think.
Here. Here.
We'll move to the next question. And Tracy figured out her technical difficulties. This next question is for Jason. You gave a great example about the discussion that you had in your prior role as an IT director of your health center with the HCCN about how you can work together to achieve your HIT and data analysis goals. What advice do you have for other HCCNs or health centers who are looking to initiate or navigate similar conversations, especially considering roles related to COVID data and telehealth?
That's a great question. Yeah, thanks for asking. You know, one thing that I did when I moved to the HCCN was to start a collaboration between all of the health centers at the technology layer because I knew there were 19 other organizations like ours, but I didn't know them and I didn't have a way to collaborate with them. And so we started a group called the Health Technology Network, not ironically the HTN for hypertension acronym. And so that group is still meeting monthly today, 15 years later. And so now what we try to do is to create these collaboration layers across each health center. We're working on the kind of SQL database developers, the business intelligence developers, as well as the IT and security folks. And so that's probably the best thing that we can do. And then, of course, the technology systems that I walked you guys through just a little bit ago are intended to try to leverage the expertise across each one of the health centers so that we actually can be stronger together in that model, so that it's not a bottleneck on the HCCN that needs to be producing things that's sometimes could feel in competition with the health centers. So I'm trying to figure out the model to bring everybody together into a shared development environment to where everybody can kind of win and kind of move everything together faster than they could otherwise.
Great, thank you. Our next question is, have you built automatic data feeds into Tableau data visualizations for the dashboards you are showing today?
We did, and so our COVID surveillance system updates every 15 minutes from the HIE data feeds, and so as an event happens at the hospital, it immediately feeds into the HIE in Colorado called Corio. We then have a real-time feed from Corio into our system, which then processes that and sends it into the report. And so every 15 minutes when that gets updated, we also update the patient list, people that need to be followed up with, and then we can make that available to the health centers in whatever way they want to be made it available to them. We can just make it available through a dashboard, or we can send them an alert over email. There's lots of different ways we can do that. So yes, we definitely have connected those dots this last year.
Great, thank you. And we do have a number of additional questions in the Q&A, but it looks like we only have about a minute left. So I believe we'll be able to respond to you offline and get answers to you. So I'll turn it back over to Ron for some closing comments.
Yeah, thank you, Anna. Again, I apologize for the technical difficulties. Sometimes it's on either end. So thank you for putting up with that today. But I want to thank Tracy and Jason again. Thank you so much for your insights and for bringing this all together and giving us confidence in the field, really, of what's going on. It's amazing the work that the HCCNs are doing, and along with the Bureau. I thank you for your objectives, Tracy. You shared where you're trying to modernize things and bring us forward. And I think we are able to tell that story well, whether it be state legislators or Congress or funders. So thank you so much for that. And thank you all for joining us. I just want to remind you, upcoming next week, we have our webinar number 3, the future state. So we did the past, how where it came from, present, and in the future. We're looking at data integrity. So that'll be next Tuesday, February 2nd, same time, 11 to 11:45 Eastern. And on top of that, we're going to continue a series. So we're going to create some learning communities, and these series will run February through May. And so we're going to focus on virtual care. We're going to use our Million Hearts self-measured blood pressure as an example. We're going to look at data validation, and then finally user experience and human-centered design. So I think there's going to be really impactful and learning communities for interaction and learning together. So if you missed any of these, and of course I apologize again for the slides, this will all be on the NAC website, so you can go there to find out. If you're attending this webinar, you're already registered, so our team will send out some invitations to you to remind you about these learning communities. So that will be coming soon. So again, thank you all again. Hang in there with this COVID. I know it's been long. We're coming up on a year, but I think everybody's stepping up. So appreciate all your work, Jason, Tracy, the Bureau, everybody pulling together to help our population. So thank you everyone for what you're doing. Stay safe and healthy. Let's keep at this battle. We're going to overcome it. So everybody take care, and thanks again to our team for a great presentation today. So take care, everyone. We'll see you next week.
Thank you, Ron.
Thank you.
Thank you.
Thanks, Tracy.